Hey everyone, Dr. Danthalery here again, or Dr. D, bringing you to the next video in the revisional surgery series. And of course, as always, I work in the lovely Atlanta, Georgia with the best group in town, Beltline Health. And so let's get started. So today we're going to talk about, in our revisional bariatric surgery series, the gastric bypass. I'm going to go over various patient scenarios, talking about common ways I've seen this go down. Basically, if you're a patient out there that's had a gastric bypass in the past and you're having issues with it, or you're looking for ways to re-engage with a bariatric focus group to either optimize results or start getting results again, you need to come on and see us. But I hope with this PowerPoint that I can educate you on what to expect and how things would normally go. So let's get started. This is a picture of the gastric bypass in general. Now, I have a separate video on the gastric bypass and how it works, so I'm not going to go over um, the full explanation of the Roux gastric bypass, but here's an image. And I guess briefly, what happens with the gastric bypass is we make a small pouch for your new stomach. That's the restrictive part. And then we divide intestine and reroute it such that food can't mix early on, which normally happens here. And normally we would have 16 to 20 feet of intestine from this point to this point to extract every little calorie out of what you ate. But when we reroute things, food is now going to travel a few feet of your intestine without getting broken down necessarily as effectively or efficiently. The things it needs to break down do meet up with the food just further downstream, which is right here now. And I estimate when we do this, that we leave patients with anywhere from, I usually say 10 to 12 feet of intestine to do the work of normally 16 to 20, and this is called creating malabsorption. So what are some common bypass issues and or complications? Well, um, here they are listed. Failed weight loss or weight regain is probably the most common reason I start seeing people for revisional surgery related to the bypass. This can be paired with or without a reflux or heartburn issue, and we're going to go into the details of those issues and how they work. Now, what are your options in general? I think this is a good summary slide. No matter what, you need to realize that what we do next is kind of dependent on your insurance and what kind of symptoms you're having. As always, I start by looking at patients and determining, are you really dealing? Are we dealing with an emergency? How urgent is it for us to proceed to the next step, whether it's actual surgery or some kind of workup? Um, Everyone coming to Beltline Health for revisional surgery gets automatically plugged into our medical weight loss program, and I'll touch on that. But the main reason is if you've regained weight with a malabsorptive surgery like the bypass, it means you need some extra help and education to get on board with that lifestyle modification. Because guess what? You're about to undergo a probably the highest risk operation that we do in weight loss surgery, which is revisional surgery as it pertains to a gastric bypass. And this is your last chance to get it right. So we want to make sure you're on board because somehow the system failed you before and or some stress in your life caused you to go off track. We got to get you back on track for your safety. As I talk about the options, it'll be clear why. You run the risk of certain complications. That risk of complications goes up after your revisional surgery. So if we weren't able to drive home the points the first time, or you had surgery somewhere where they don't have a robust program or offer follow-up, or you moved into town, etc., it's just so important to understand what you're getting into, understand the importance of following up and changing your lifestyle and diet modification to get good results. Because again, this is your last chance. Bypass preserving anti-reflux procedure or surgery, that could be one direction we go where, hey, you have a tool, it's the bypass, it's still actually working. You've had a modest or minimal weight regain. You're actually having some symptoms that we need to isolate and focus on. Then from a revision standpoint, we primarily talk about a couple of different options. When we revise surgery, we're going to leave your original surgery the way it is overall, and then we're going to change some aspects of it. That can involve pouch resizing and or limb lengthening. And I put a star by that because that's the primary option at this point if we are going the surgical route and you qualify for that. And then last but not least, and when I said you're about to have the most dangerous weight loss surgery, in a revisional context, this is actually what I'm referring to in terms of risks related to revisional surgery. Going from a bypass to a duodenal switch, in my opinion, is the highest risk option to undertake and go through, and I'll tell you why. So for scenario one, let's talk about a patient named Jane Doe. This is a patient that had a bypass recently or many years ago. They don't have reflux symptoms or regurgitation problems, and they still feel a little bit of restriction, or maybe a lot of restriction. That's where you feel full with a couple bites of food. Um, there's maybe no weight regain, or at least a modest weight regain, less than 25%, we'll call it, and the BMI is still less than 35. This is a patient that just got off track or had surgery elsewhere, let's say in Mexico, and never really had a robust follow-up program to help utilize that tool properly and maintain weight for a long term. So this person is probably wondering what to do. First things first, you got to come to clinic. I think first step in accomplishing anything really in life is to just show up. So show up to our clinic, come with plenty of questions, and have an open mind and be ready to commit. And we're going to take good care of you. Discuss the desirability for the bypass maintenance versus a conversion. That's going to be the goal of or the topic of our consultation when you come in to see me to discuss revisional surgery. And we're, of course, going to end the day by talking to a coordinator. They're instrumental in all of this. They know what your insurance actually says about whether or not revisional surgery is covered. What are the cutoffs? What are some hurdles we may have to overcome to get safely and efficiently to the finish line? So what's next? So this is a patient that still has a tool, in my opinion. They have a good gastric bypass. It's not giving them symptoms. They just regained some weight, and we're in a small, modest amount of weight regain that I think is very capturable with strong education, actually getting with the program, having some accountability, and of course there could be a role for some of these medical weight loss drugs. So you're going to join the Beltline Health Medical Weight Loss Program. This will include a consultation with our professional medical weight loss doctor, who happens to be the finest in town. New medications which are available that we can offer. It used to be that we only had medications that you could expect like a 10% weight loss with it and a less than 10% success rate at maintaining that weight you lost at 1 year. Well, that seems to be changing, and I'll defer to him to kind of tell you what's available and how well they work. But I'll just tell you briefly, we are seeing 15 to 20% weight loss these days with some of these medications. You're also going to be introduced to your own dietitian, someone you can check in with periodically, and we want you to talk to your dietitian and or your medical weight loss doctor or nurse practitioner who's part of the team. The moment you feel like you're losing some steam or you're hitting a nadir in your weight loss, these kind of things, these are the perfect times to handle it. Letting that weight regain or your stress or issues compound and seeing us once stubborn weight's been put back on you, then we're going to be talking about surgery. And the name of the game, honestly, when you see me for a revisional surgery consult, I'm going to say it over and over again. I want to solve your problems without surgery if at all possible. These surgeries, from here on out, scenario 2, 3, 4, it's going to involve surgery, and I'm going to highlight some risks. Some of the most complex and high risk surgery we do is starting with a bypass and revising it or converting it to something else. So, if we can help you accomplish your goals, make you happy without doing that, I think that should be your primary goal. Um, of course, we have at our office access to one of the best body composition scanners and scales in the market. It's as of this video, it's brand new and it's has all the latest technology and bells and whistles to give you very accurate reporting of, for example, free fat mass, skeletal muscle mass, water volume, weight, etc. So please come and take advantage of that. In the next scenario, we're going to talk about a patient named Jenny Doe. This is a patient that had a bypass many years ago. Maybe this person's not having reflux or regurgitation still, but they've lost their restriction. So now, a common thing I hear, Dr. D, the first year after surgery, after my bypass, golly, I could barely eat a few bites of food. I was eating like very scant amounts of food on my plate and I felt very full. Fast forward several years, 5 years, 10 years, Dr. D, I can sit at the table with my family and have a meal almost the same way I used to before I ever had surgery. That is a loss of restriction. probably the pouch is dilated and stretched out, and it can accommodate more food. So especially if you're someone who is relying on that, and if you come see me, I'm going to tell you day zero that restriction is temporary. You can't rely on that. You got to learn how to eat around that sensation of, by the way, we're wired to do this, so I'm not picking on anyone, but if all we do is eat till our stomach tells us to stop, well, with a little pouch, every time it's telling you to stop, it may be stretching to accommodate a little more food. I tell people we got to rely on visual cues. You got to find other ways, again, revamping your relationship with food to find physical and psychological satiety with an appropriately portioned meal. Easier said than done, obviously, but that's where I think these tools help you explore that relationship. And the ones that can hammer it home and stick with it, those are the ones that have long term success. So I'll tell you from day one, it doesn't matter what surgery you pick, restrictions temporary. Um, Now, let's say this patient had a greater than 25% weight regain, that BMI is now north of 35. Maybe a medical problem that was previously cured is now back. That's usually alarming enough for people to come knocking on our door. So this is a patient that got off track and now actually has a medical problem. What to do? Show up. Let's discuss your desirability to maintain with your tool. See if we can capture you. What are your goal weights? What do you want to get out of this? And if not, we can talk about a revision or conversion. Of course, we're going to talk to the coordinator. These are going to be recurring themes. What's next? Your tool may or may not be still useful to you, so we're going to explore that. And this is a simple discussion. We're going to look at your current weight. What was the nadir weight? What was the lowest weight you got to with your bypass? So we have a sense of how your body responded to surgery. And let's be honest, when you come to this consultation, talk to me, kind of be direct and straightforward. Don't be bashful. If you fell off track because of some controllable reasons, we want to know that so we can do it differently. Again, you're seeing us for revisional surgery. This is your last chance to get it right. So let's try our best to do that. All right. So as always, all our revisional surgery patients have to join the medical weight loss program. Can't hammer that home enough. I get negative feedback all the time that they're torturing us. Why do I have to do 6 months? Why do I have to do a year of medical weight loss? I know it's not going to work for me. Well, you can't have that attitude. You got to be all in and prove it to us to undergo these risks for surgery. I mean, we're all doing this for you. We don't, not in the business to just, cut bill and move on to the next one. We really want to see you do well. There's a reason for everything we do. It's just so much better for your safety to really buy into the program. If you're doing this for 6 months or a year, don't forget that probably for 5 years you were off track before you came in. I know once we make up our mind in an age of Amazon or whatever, like, I know I want something, so now it's got to happen. Well, it probably the weight regain won't like have a negative impact on you for another 6 months or a year. Try to get these habits down because once we do the revision, again, I'll point out that the percentage risk of complications, malnutrition, etc., skyrockets. You got to get it down. This is your last chance. So that's why we're not in the game to torture you. We just want to really push you to have the best results. Now, what are we going to do next? Now we can prepare for a revision if that medical weight loss period failed, it didn't get you the results you wanted. Um, and at least now if you came from another program too, by the way, this is another advantage. You know our program, our dietitians, our manual. So there's no question about, oh, I used to do it this way or that. So once you've checked those boxes, now we're going to talk about these surgical options. What are they? Limb lengthening with or without a pouch revision, and something called endostitch. Now, note, technically, we don't currently offer this. Dr. Proctor, Eduardo, and myself, we don't do this in our practice. I have done it in training, but and I'll explain later, don't believe strongly enough in it to add it to kind of our armament. I think I'm going to look into doing that and offering it in the future. But I will touch on what this option is. And if you're seeing this and you already have heard about like endoscopic opportunities to revise your bypass, certainly, and you make it this far and we're talking about it, I'm certainly not bashful. If that's what you want to explore, I'm going to recommend someone or recommend you find someone in town that does it. But we can certainly talk about what is it, the role of that for your success. Now, scenario three, let's say patient Jackie Doe. This is a patient that, again, had a bypass many years ago, not a sleeve. I apologize. This patient has no reflux or regurgitation, but now has no restriction, and they have a greater than 50% weight regain. So this is now we're talking you've regained over half of the weight that you did a good job to lose. And Jackie Doe now also has a dangerously high BMI, north of 55. Probably medications aren't ever going to get you out of obesity. Hypertension is back. Maybe there's a new onset of type 2 diabetes, sleep apnea. This person's way off track, and we got to do something. This box stays the same. What's next? The tool is no longer useful for sure. Join the medical weight loss program, mandatory 6 months. Sometimes we'll say longer. Depending on your history, maybe no surgical options for you. I'm going to touch on that when we get to the next slide with pictures. But we're going to prepare for revision or conversion, whether that's limb lengthening or pouch revision, or rarely duodenal switch conversion. So now I don't think if your BMI is this high, you've had this level of weight regain, you really need to be thinking about an endoscopic option to revise the connection point. Statistically speaking, that's not going to get you the weight loss that you really need to start affecting these medical conditions that you've developed, which are really over long-term life threatening. So that is the general um, kind of cadence of how things would go depending on symptoms and level of weight regain. Now, here is scenario 4. Patient Joanna Doe had a bypass recently or many years ago, having reflux and regurgitation, but still has restrictions. So this is a patient now, and I'll go ahead and read the next bullet. No weight regain or less than 25%. So we're back to someone who still has the tool, they have restriction, minimal or modest weight regain, something we could still capture with diet, lifestyle modification, medications. But we really, it's the reflux regurgitation at this point that's really taking over their life. I'm having burning chest pain after every meal. When I lay down at night, stuff is coming up. 3 weeks ago, I had to go to the ER for a pneumonia. These are things that just scream regurgitation reflux issues. Now, what to do? This step stays the same. Come to the clinic. Let's discuss options. Let's see what the coordinator has discovered about your entrance, that whether or not this is actually feasible, cost and timing of things, what tests we need to do and schedule. So what's next? You still have a tool, but we got to figure out what's wrong here. So this is where we're going to send you for testing. We're trying to figure out what is the cause of these symptoms that you're having. That would involve an upper GI, drinking contrast, shooting a chest X-ray. We probably will do an EGD, esophageal gastroduodenoscopy, or upper endoscopy, where I run that camera down. I want to look at your anatomy. I want to see that pouch. What's the shape and size of it? What's the opening look like at the bottom of the pouch? These are points of potential issue, and can't make a definitive plan for you until I know exactly what's going on. pH testing and manometry. These are more advanced reflux or heartburn related tests. We want to know, what's the acid level down here? I mean, some people confuse regurgitation and reflux. Yes, it feels like sometimes the symptoms overlap. It's not classic heartburn, it's just pain and tightness, dyspepsia and bloating. But sometimes we may need to know, actually, is what you're experiencing true acid reflux, or is it really that you're regurgitating? It's not necessarily acid, it's stuff you've eaten. So pH testing can help with that. Manometry, that's measuring the pressures that your esophagus can generate to kind of push food down. Sometimes we need to know if there's a primary esophagus problem going on. As always, you're still going to join our Beltline Health Medical Weight Loss Program. And the test results, those tests that I just highlighted up here, those are going to determine what we do next. So what are some possibilities? We do an EGD and a dilation, for example, if I've found something called a stricture at that connection point, or do we need to do some kind of revision? So that's how testing helps us actually tell you what we need to do next. Okay, so this is kind of a busy slide, but this is a summary of those scenarios, and I've laid it out here with pictures to kind of describe the way things could go. Again, here's the original bypass, just like we started our kind of presentation today with. Roux and gastric bypass. Scenario 1, Person with no reflux, happy, recoverable weight. Remember that less than 25% weight regain. This is a person that just may need guidance. We need to kind of re-educate on how to eat properly, chew well, slow, timing of meals, what kind of quality nutrients are you putting in. You just need a dietitian, nurse practitioner, accountability, fancy weight scale to measure where the weight is distributed and how to work on it, etc. You're going to join the medical weight loss program if you fall into that scenario, and that's usually a minimum of 6 months. And we'll kind of go from there. And by the like I said before, we don't want to just keep you on something that's making you unhappy. We want to revisit and prove that you've kind of put in the work and you're trying. You could always come back to the table to discuss, like, yeah, I made some progress, but not quite what I was expecting, and you may still be a surgical candidate. So that's what this next part of this will show you, but I want to again highlight the different scenarios. Scenario 2 and 3 was someone not with reflux symptoms, but had a modest or severe weight regain that now you're pushing BMI greater than 35, but maybe not quite up to 55, or now you're over 55, you have medical problems. So again, medical weight loss program is where all these things start. That's what I'm trying to show you here. And so let's run with those two for a second. Scenario 1, 2, and 3. Medical weight loss, try it for 6 months and you're happy, you've avoided a risky surgery, just stick with the program. If you're not, this is where we start talking about what are those actual surgical options. I mentioned briefly endostitch, something called endostitch, and then we're going to talk about revision and conversion. Revision being keep your bypass structure, this basic unit here, this basic structure, but kind of I say, like, touch up the edges or, trim the hedges, so to speak. We're gonna go in and kinda revise the existing Roux bypass versus a true conversion to another weight loss surgery. Typically, we're talking about a duodenal switch. So, that's how I want that kind of algorithm to go for those scenarios. Now, scenario 4, this is a patient that had a happy recoverable weight, but mainly seeming for reflux. Now, I wanna touch on this. We typically talk about a bypass as being a quote anti-reflux surgery. If you have bad reflux and an unhealthy weight, you may have picked a bypass appropriately because it had the highest up to 85% chance of curing your heartburn problems where you don't need medicines. And of course, 85%, sometimes you can get 60 to 80% excess body weight loss. So you may have picked a bypass for that reason. And here I am telling you, well, why would a patient have reflux? Well, that's where the testing comes in. I will tell you by and large, although we consider the pouch, the gastric pouch, and the connection because there's no valve there, technically it's a low pressure system. There's fewer acid producing cells in the pouch too. That's why it's generally curative for heartburn. But if you are a patient that has heartburn heavily induced by an unhealthy weight and diet and eating habits, and you've regained weight and you've kind of falling back on old habits in terms of what you're eating, how you're eating, when you're eating, well, guess what? It doesn't matter what the system looks like. You can overcome it. It's just like having a dam that where things can spill over. So what happens in a pouch is if you're not chewing well, taking small bites, chewing well, not drinking liquids with your food, all these basic things, you can fill your pouch up, especially in a scenario where the pouch still doesn't want to stretch much and the connection, the anastomosis at the bottom is still a pretty tight drain, then guess where things are going to want to decompress? Back up. So sometimes the reflux or regurgitation is strictly related to improper eating habits. You're no longer using your tool properly. But sometimes there's actually a technical issue. Maybe you've had a complication after your bypass. What are some examples? A stricture or an ulcer has caused a tightening of the bottom of your pouch, and that's what I'm showing here. So remember, I would have sent you for a workup, an upper GI that shows a delay of contrast leaving that little pouch and not going down, and it can confirm if things are shooting back up. We may do an EGD, and now this is a representation of that. What you're seeing here is the very bottom of the pouch, the drain at the bottom of the tub, is really small, and I mean, I don't think you need to have a lot of experience to say, like, "Oh, that looks like kinda like a little pinhole down there." Well, one thing we can offer, and this when we see this, typically it's in the earlier periods after your like a recent bypass, again, like in Mexico or another state, and it just wanted to heal tight, well, we may have to run that camera down and put a balloon through there. That's what you're seeing here. Technically, this is called a balloon dilation, and we put this plastic balloon across the hole. We inflate it with water, and we can very accurately measure the pressure we're applying to this area. And we kind of sit and count time, and we do a few rounds of that. And we never push too hard because we don't want to cause an injury. But sometimes after we're done, we can see a result like this. Look how big we've made the drainage hole at the bottom of the tub there. So now imagine this is less likely to cause things to want to shoot back up your throat, more likely to drain down into that intestine where it's supposed to. So that's just one example of something that we could catch on the studies we're going to order and kind of offer almost an immediate resolution for. Now, let's say that's not the case. You're not having an ulcer related or unrelated stricture. You're having some other reflux issues that are more really related to your anatomy. Do you have a recurrent hiatal hernia? Were you always going to have reflux? The bypass didn't solve it because the lower esophageal sphincter is just not doing the job it's supposed to, etc. Well, then we would go down this way, and you would have a couple of options where, again, you're happy with your weight. We can reuse the tool. We actually got to correct your heartburn to get you on track losing weight. So I've also seen this where patients want to eat a kind of a dense protein, high protein, low carb diet, but guess what causes heartburn reflux symptoms? Things that don't break down well and easily. The dense proteins are actually tough to eat because it's causing such bad symptoms. So what do people eat to get by in a busy society with your job and the demands of life? You're gonna just eat some carbs. Why not? They melt in your mouth and they trickle through here. It makes me feel better. And before you know it, several months of that goes by and you've regained a bunch of weight. Well, if that's the case and the reason for your heartburn is something we can work on, like a hiatal hernia, and we can preserve your bypass so you can continue to eat those dense proteins and kind of lose weight and get back to a happy place, then we want to do that. And this is a picture of a hiatal hernia repair. This is the diaphragm muscle and the esophagus where it's coming out. Technically, this is a sleeve. I couldn't find a picture of a bypass, but the idea is the same. We want to make sure the last part of that esophagus is in the belly where it belongs, and your pouch, we want it in the belly, not in the chest. And we may need to reinforce a hiatal hernia, especially if it's a recurrent one. What they're showing here is like a sheet of mesh. The other option, and I think we're on the cusp of having some good data as it relates to using this device, the Lynx device, in prior weight loss surgery patients and seeing good results. So if you're a candidate for this because you have the appropriate pH manometry testing, I think this is a video series in and of itself. Stay tuned. I want to do that for you, but um, where I will talk about the technical details of putting a device here to prevent heartburn. Again, these are situations where you want to preserve that tool. We just got to isolate and focus on the heartburn aspect of your symptoms. In this next slide now, we're focusing on the surgery side of things. So carrying over from the last slide, as you can see, I've separated off the reflux stuff. Let's say you're someone who has a bypass, you're not in the reflux arm anymore. We're dealing with a weight regain, medical problems. Now, all Beltline pathways still go through medical weight loss. We're not going to cut corners there. And then we're going to talk, I want to talk a little bit about these options. Now, option one for revision, the most common thing, and usually what I'm going to advise, this is as far as we take it, is something called a revision of your bypass or a limb lengthening. Also, it's called a distalization, a distal Roux-en-Y gastric bypass as opposed to a short or standard Roux-en-Y gastric bypass. And that's going to be one option. The other option is conversion. We're going to save this for people who I like to say you got big medical problems, big weight regain, you need big gun treatment. Well, the duodenal switch is about as big of a gun as we can offer for having an unhealthy weight. So I'm going to go over that too. On this slide, I want to focus on this option briefly. Again, we don't offer it, but you can certainly find people in town who can do this. Who is this for? And what is it? It's called Overstitch. It's a technology where with certain instruments using that endoscope, the same camera we use for upper endoscopy, slightly bigger one with a bigger channel on it and some attachments, but we could go down with the camera and we can alter the size of that drain at the end of the tub, the anastomosis. One thing that's associated with weight regain, again, if you were not educated on the importance of restriction, and also I should say the transient nature of restriction, and over time you just eat until it tells you to stop. Well, this is an example of a pouch that's gotten dilated from this size up to this size, and the drainage hole at the bottom, which used to be nice and tight this size, is actually much bigger. The reason that matters is if the drainage hole at the bottom's wide open, guess what? Food's not going to hit that and make you feel full. So now you can accommodate more food. There's less restriction. So Overstitch uses that device, little pincers at the end of the camera to kind of place a stitch on both sides of the hole and cinch it down. And so we can narrow the hole at the bottom of the pouch to re-engage some restriction, kind of delay the transit of chewed up food from the pouch into the small bowel. And so all those things can help people kind of get back on track. Now, what does the data say? Honestly, this is why I think at Beltline we're not doing this. Unfortunately, the majority of the time, I don't get a scenario 1 or 2 patient. It's usually scenario 3, where the weight regain has happened. It's we're not at a point where we can recover it with a modest procedure like this. Now, this is a great option if you've had a mild or modest weight regain and you really do have a big pouch. But at the end of the day, when I think some 130 patients in the largest study I know of that looked at this had this procedure done for a modest weight regain of about 25%. They ended up losing, at most, at 6, 12, and 18-month follow-ups, somewhere in the range of 8 to 15 kilograms. So we're talking like 16 to 30 pounds. And if your BMI is over 55, or even 45, north of 35, let's just say 40, greater than 40 to above 55, I don't think it's worth it, and as far as I know, perhaps insurances aren't necessarily covering this, but I may be wrong about that, and that's where the coordinator could figure that out for us. But I don't see a point in doing this if you're going to need a modification to get to your goals. So that's why I bring it up. I certainly want to, in the future, be more comprehensive and have this option available. Here around Georgia and Atlanta, I'm not seeing as much of a role for it just yet. So that is the overstitch option. Okay, now I want to talk about in a little more detail what the primary revisional surgery option is for your gastric bypass. We call it a limb lengthening and pouch revision, and this is basically what it looks like. Remember the other two, the names, just to define some terms. Your traditional gastric bypass, another way to think of that is a short gastric bypass or a standard gastric bypass, and and that's typically how I would describe it too, especially if you had a gastric bypass before the 2000s, maybe even before 2010. I find that older surgeons, they were either intentionally or unintentionally somewhat conservative. I think they were doing it the way they were taught, so worried about malnutrition because I think not that long ago, especially a few decades ago, we did these things as surgeons and didn't pay much attention to the aftercare and the follow-up. At least some didn't. So, and also I think for efficiency and doing it quickly, these little modest gastric bypasses were done. And a factor of things have led to us being a little more aggressive. Some of that is knowledge, research driven, knowing that it's safe, but education, vitamins, nutritional supplements have gotten a lot better. And as a result of that, and having other also better technology, laparoscopic techniques, robotic techniques, especially, we're better able to kind of count and test and do these connection points a little differently. But what I would tell you is if you're seeing me and you had one of these older bypasses, let's just draw a line in the sand before 2005, probably you can bet, if I was a betting man, I'd say you had a pretty conservative gastric bypass, maybe a 50, 75 centimeter alimentary limb and a 50, 75 centimeter Roux limb. That's the biliopancreatic limb. And when these are short, you got to realize there's a lot of bowel left over beyond that point. And now, since that time, it's actually been proven that shorter biliopancreatic limbs and less less importantly, but also a factor, longer common channels were a reason for modest weight loss. And so that's where there's an opportunity to revise this. And so let me just tell you technically how it works. When we talk about limb lengthening, there's a type 2 revision and a type 1 revision. Type 1 is the most common, it's the one I favor, and it's the one that's associated with better results. The way that would work is, again, here's your gastric pouch. It's connected to the alimentary limb, which is going to bring food down here. It's going to meet up with the biliopancreatic limb, the other side, bringing those digestive enzymes that we need. And what's happening is perhaps, again, if this was done modestly, you may still have extra feet of intestine for a common channel. Remember, when I do this, I think I'm leaving you with depending on where you start, do you have 16 feet or 20 feet of intestine? I estimate that's why when I do it, my traditional bypass, it could be anywhere from 10 to 12 feet, but it could even be like 8 or 9 feet to 10 to 12 feet, again, depending on where your intestinal length begins. The bottom line is, if the more feet of intestine that's left behind here, if you think about it, that's more surface area to absorb calories, i.e., you have less malabsorption. So when we talk about limb lengthening, what we're talking about doing, at least the way I favor doing it, is ensuring that I've lengthened your biliopancreatic limb. And regardless of which limb we choose to elongate, what we're also effectively doing is shortening the common channel. So that's actually why sometimes I'll call this, just to kind of separate those two facts, we don't know which limb is lengthening, but we're definitely targeting a shorter common channel. So sometimes I'll try to call this a limb shortening. So if you hear me say that, I kind of interchange, but I think that the most apt and probably more accurate way of describing what we're trying to accomplish is a limb shortening technically. But because there's three limbs, what I'm referring to when I say it's the common channel. So anyway, I'm just gonna try to keep it simple. But you can tell I love this stuff and I want to talk to you about it in detail. But when I do this, what I'm usually gonna do is ensure that you have a minimum of 85 centimeters here for a biliopancreatic limb. That measurement's been associated with some kind of anti-reflux properties. So we want to make sure you have at least that. And then what I'm gonna do is cut the alimentary side, the red arrow side, off, and then I'm gonna march it down, and when I march it down, we actually don't count this way. I may start from the end and count back, and I'm gonna count back about 250 centimeters. And that's gonna ensure that we're leaving the least amount possible for your common channel. That's gonna allow us to maximize weight loss, but at least limit that chance of malnutrition. I'm going to talk about that in a minute. But what we're doing is cutting it off on this side, marching it down as far as we safely can. I usually don't want to go below 200 centimeters for the final length of this, and I'm going to reconnect it there. So now what happens is when we do that, your food still travels the same distance, but guess what? The enzymes that need to break that food down, they have to travel a longer distance before they meet up with the food. We're decreasing that surface area, especially if you had a modest bypass and you still had over 12 feet of common channel from your original surgery. Marching it down several feet, like another 8 feet or 9 feet, and leaving you with 7 to 8 feet is going to really re-engage that component of malabsorption. And this is why I tend to tell people that the results for this vary. Okay, so now let's talk results and complications. Let me start with results. Sometimes we do this surgery, and honestly, even as a surgeon, I've been a little let down. Now, there could be patient factors. Patient claims to be following the program, but actually they got the limb lengthening and they're eating junk and not exercising, maybe. So let's pretend we always have ideal patients. Sometimes we don't see results, and it could be a couple of factors. Number one, I already alluded to it. But if you happen to have a bypass that was already fairly aggressive and there wasn't as much room for me to like kind of march down, for example, if I cut this off and I walk 4 feet and realize, hey, I'm already at my marking stitch where I said I wanted to leave him with really 8 feet of intestine. Well, I've only given you, 4 more feet of malabsorption. That may not make much difference. So that's factor one of why results vary. I think patient factors. Factor two, how much was bypassed the last time and how aggressive is my distalization, the limb lengthening? Because do I have enough room to do an aggressive distalization or limb lengthening? And then last but not least, factor three, genetic and also adaptation. You already had the bypass. You may be someone who had a bypass for years, over a couple of decades at this point. Well, something I tell everyone, just like restriction doesn't last forever, and the way we were designed, incredible adapting machines. From the moment you had your gastric bypass, guess what your common channel was doing? It was actually adapting. It was learning. In some ways, mechanically, this happens. It elongates and stretches in diameter to pick up the slack of having less effective intestine to absorb calories. So remarkably, something happened that's called hypertrophy, where your common channel may have already adapted over the years to get better at absorbing calories. So maybe it doesn't matter how much we bypass because that intestine's already figured out the game and it's going to continue to extract calories from what you're eating. So keep all those things in mind, but that's why results vary. However, in some of the data that I've reviewed, we can see sometimes when we do that type 1, moving the alimentary limb down, effectively lengthening the biliopancreatic limb and shortening the common channel. In the studies where the surgeons did this, they actually left 100 to 150 centimeters of common channel. That's more like 3 to 4 feet. And when they did that, they measured actually 61 to 90% excess body weight loss. That's like starting over. And I will say that too. I talked about results varying, and I talked about how you may have modest weight loss and be disappointed. I should have mentioned, I forgot, and I moved on. You could have extreme weight loss results. It could sometimes doing this revision is like starting over, especially if all those factors come into play. Your commitment, maybe you haven't had an adaptation period that was as long, and actually you had a modest bypass, and we were able to bypass a lot. And and actually, in that scenario, we could see similar weight loss results to the first time you had the surgery. But now I want to transition into complications. Why do I hesitate to do any revision or especially conversion? And I'll hammer this point home when you come see me in person. When you had your original gastric bypass, you should have been quoted a risk of leak or infection in your belly that could range from 1 to as high as 2.5, some studies 3%. When we do revision surgeries, conservatively, that risk doubles. So you're looking at a 2 to 6% chance of a leak with a revisional surgery. And yes, a very small percentage, there's a really, really small chance that you actually die from a leak or an infection because it's so recoverable with CT scans, antibiotics. Maybe we go back to surgery, drains, etc. But I bring it up because it's a miserable thing to go through. I'm talking, sometimes when leaks happen, it's 3, 4 weeks in the hospital and long courses of IV antibiotics, time off from work, away from your loved ones, etc. So I don't, and then of course, I do have in the back of my mind that if you're a very sick person, you have a leak, yes, sometimes you can get so sick that you're in the ICU and it can be life threatening. So I don't want to be guilty of downplaying that, but the fact of the matter is it's a high leak risk, and that's why I don't take it lightly. I don't want to do this and you're not committed and you're just going to regain weight. And in the short term, I don't want you doing something unsafe and provoking a leak too. So that's why it's so important for our 6-month medical weight loss program and going forward, accountability and follow-up. The other thing I want to bring up, referring back to that study that I was quoting where we can see exceptional weight loss results with these revisional surgeries, the limb lengthening. Um, Unfortunately, while there were great results in that study and the reviewed data, the combined protein and sometimes protein calorie malnutrition has been reported to occur on an order of 8 to 31% of cases, such that a patient actually needed IV nutrition supplementation. Now, I think we've gotten a little wiser. I wouldn't push someone to 100, 150 personally. That at least makes me nervous. But if you're starting at a super high BMI and your weight is actually killing you, we can make an argument to be more aggressive with a planned intervention if you're getting malnourished. But we also have to understand that this data, although it sounds scary, I think it's a very controllable factor. Malnutrition, I think it gets billed as an expected outcome from surgery, but it's because the majority of surgeons out there do these things and don't have a robust follow-up program. Maybe they're not checking your vitamin labs frequently enough, insisting on you following up, plugging you in with a medical weight loss doctor and nurse practitioner, and insisting on yearly or biannually following up. That's how people get off the program, and if you don't follow, again, that diet education, you could really hurt yourself when we've done a limb lengthening, and I don't think people understand how quick you can get low on critical nutrients when we bypass the majority of your intestine. If you're listening to this and you already have a duodenal switch or SATY, I wanna hammer that home. You are at risk for malnutrition. You always were the moment you picked that surgery. Very avoidable in modern era, in my opinion, with the variety of vitamins we have, nutritional supplements, ways to stay on track, vitamin labs we can order. I think, like, you have to be pretty negligent to get malnourished, but I don't wanna say that it's hard to get malnourished. It wouldn't take long after a long bypass or a distalization, distal Roux gastric bypass, to get low on critical vitamins. So it's just so important to continue to follow up and take vitamins. So those are the 2 reasons why revisions can be a big deal. Now you understand how the limb lengthening works. Of the 2 main options for revising your bypass, this is the safer one. Um, and Again, it's called a long Roux gastric bypass or distalization. You'll also hear me call it a limb lengthening or a limb shortening, depending on which limb we're talking about. And before we leave this slide, one point I mentioned the pouch revision. Some surgeons aren't a fan of reinstituting the restriction by redoing the pouch and the connection. I'm a fan of doing that. I think if especially you're someone who's going to respond to having restriction, this is a second chance to get it right. So now you're going to hear me say like that restriction, look, you've already proven to yourself restriction doesn't last forever. Here's how you make it last. Let me give you that restriction again because obviously if you're seeing me, we do want to maximize and get dramatic results. So if it's safe and feasible to do that, I definitely will do it. That involves, I'm going to use my arrow here, I call it kind of trimming the hedges. Usually the pouch stretches wider than it does long, and there's this flap of extra stomach over here. And especially if I can get around this without disturbing this, because if I like the diameter of the drain at the bottom of the tub, I want to leave it alone. I don't want to introduce another connection and added leak risk. I may just put the tube in to calibrate the size and cut along the side of that to give you a new round of restriction. If you have a huge drain at the bottom of the tub or a huge anastomosis and you have enough pouch length, sometimes pouches didn't stretch enough where it's safe to do it. But if I can get my instruments above and below the drain, which is right here, I could actually redo the whole thing where I pull the bowel up and reconnect it here. So you have a nice tight connection. So mainly we focus on this part, but if it's feasible, I'll do this. And that is the limb lengthening. The next surgery, this is a true conversion. This would be converting your gastric bypass to a duodenal switch. I don't like doing this. I reserve it for people who really need it and deserve it and who show commitment. One straight off the bat, I want to say if you've had an open gastric bypass, by the way, um, the chances of us proceeding to surgery start to go down. And unfortunately, open surgery, especially if you had an open bypass and a complication, a leak, you had drains in your belly, if you have memories like that, and then you had a hernia and you have a huge hernia, we're probably not gonna do this because just the chance of complications are too high. And so keep that in mind, but it's between me and you. We need to talk about your case specifically. Talking about the conversion, the way it works is actually the first part of the surgery. If I can go back for a second, um, which I can't, is to reverse the gastric bypass. So the first like 2, sometimes 2.5 hours of the surgery, we're taking your bypass and reconnecting the pouch to the remnant stomach, the part that was on the outside, and reversing that part. And then we're detaching the bowel where it connected to the pouch and reconnecting it back at the bottom. So that's after kind of charging through very carefully and meticulously a bunch of scar tissue. First half of the case is just reversing the bypass. The second half of the surgery is doing a duodenal switch, which involves resecting the outside of that remnant stomach, and then basically redoing the bypass, but we're going to connect the bowel to the duodenum, and then we're going to reconnect that biliopancreatic limb. But when we do a true gastric bypass, we really are targeting about 3-4 feet for a common channel. And here is the bottom line. Why do I hate doing this? And why do I want to do it so super selectively? The risk of morbidity, chance of having an infection leak is too high. We're talking 20 to 30% leak rates when we go from a bypass to a duodenal switch. In my experience and what I've seen, if we do this on 10 patients, probably 3 or 4 of them will have a leak, and at least 2 of those will need to be in the hospital for weeks or months because the leak was so bad that they just couldn't make it at home. They needed total support, maybe reoperations, etc. Every now and then there's probably 2 patients out of the 10 that get a leak, but it's really manageable. It's mild, moderate, and it can be managed without too much disruption in lifestyle and work. And so that leaves like a 5 or 6 patients where it's just going to go perfectly well like it did the first time. And so those are really bad kind of and should be frightening statistics. Briefly, why does it happen? You have to understand something about the pouch. So where the pouch is here, when we separated it from the original stomach at about this level, we create a situation where the blood supply for the pouch is now a blood vessel that feeds in right here. And basically, the pouch has its own little blood supply. And just imagine with your eyes, it's coming in above this word duodenal. The bottom half of the stomach, this whole part and this bottom part of the stomach, everything below the pouch has some blood supply coming in under the word duodenal, let's say right here. And then, of course, the outside of the stomach still has all this blood supply. So when we go to, by the way, this is where technique matters and varies. We don't know how many little vessels were kind of sacrificed in the process of making the pouch here. So the blood supply to the bottom half and the middle half, middle lower third of this stomach could be kind of tenuous or vary depending on surgeon technique and genetics. Like you may not have as many branch vessels or accessory vessels, etc. And then of course the outside, when we reverse that and then we go to do the sleeve, which is the part of the duodenal switch, we're actually cutting out the entire outside of the stomach. So just think about that for a second. One blood vessel is probably supplying your pouch still, as it always has. But this lower third or lower 2/3 has relied on blood actually from the outside as well as from here. And somewhere along the way in reconnecting and creating space, if we lose 1 or 2 vessels over here, and we take out the whole outside, we're asking your stomach and this new connection to heal with a limited blood supply. And I think that's where the leak risk really comes from, is that we don't truly know what the vascular supply is here, and we're certainly sacrificing a significant portion to this lower third. And that's where we usually see leaks are along the outside of the new staple line here, or you have to use your imagination. But where we connected the pouch back to the stomach is another anastomosis, another connection, and those areas can get compromised pretty quickly. So that's the major trouble with this. This is why I reserve it for if you're seeing me, you have a bypass, you have to be in that scenario 3 where you've regained your BMI is north of 55, which is my cutoff for a duodenal switch anyway, and bunch of medical problems, and we really got to talk and say, I want you to have a mentality of A, I'm in it now. I'm in it to win it, but B, informed decision making. I realized that I could potentially die going down this pathway, be miserable away from my family, but it just means that much to me. The status quo where I'm headed right now is bad enough that this seems like it's something I should think about doing. So we will make that complex decision together. But briefly, that's the gastric bypass to the duodenal switch option that I'm talking about. Of course, want to bring up malnutrition again. I think that rate of malnutrition could be in that 20-30% range too. Again, very able to combat it with a robust program like ours and the education, but it's still on you to remember how serious that is and not y you know, forget to take your vitamins or say, "Hey, this month they were on back order, so I'll just order them next month." Little things like that could cause a problem, so, you wanna follow up aggressively, you wanna stick with the diet, you wanna take your vitamins, you want us to check your labs periodically. And there you go. That's actually a pretty long, robust discussion about revisional bariatric surgery, and it's the hardest one, you guys, and that's why I think I had to cover so many variables. It's the most challenging revision we do, bypass to something else, limb lengthening or duodenal switch. It's not for everyone. God willing, you can get back on track without needing surgery. And guess what? If anyone's going to help you do that, it's us as well. So step one, show up, come to us, seek out help and bring questions. We're here to guide you. As always, stay tuned for the next video in the revisional series, which is going to be about the sleeve. And as always, follow us on social media. Follow me, Dr. D Surgery, and or please follow us at Beltline Bariatric too, Bariatric Health on Facebook. We have 1,500 plus followers in our Facebook support group. I love the messaging in there, the questions. Part of our team is in there, usually responding to things too. I think that's an invaluable resource. And then new in 2023, I'm starting to get more involved in TikTok, and I want that arm of what I do to be more focused on fitness and consistency. And so I hope over time to share with you some of my exercise workouts and tips, and maybe even some guidance on how to kickstart a little exercise after your weight loss surgery. As far as I know, I'm the only surgeon offering that level of personal care and follow up for your personal fitness goals. So stay tuned for that. And until then, eat better, move more, stay committed, and you got this. Have a good one.